Hello, I'm Alonso Medina, and today we'll be presenting on neurocutaneous syndromes. So to start off, what are neurocutaneous syndromes? They are also called phamocytoses and comprise a diverse group of congenital disorders that are mostly a result of abnormalities in neuroectodermal and sometimes mesodermal development. These abnormalities define this group of diseases since the ectoderm is the primary germ layer in embryonic development that we can see right here, and then the mesoderm can also be affected by these diseases. Since the ectoderm is the primary germ layer in embryonic development that gives rise to the skin and the nervous system, this means that we often see issues in skin and the CNS. And since the mesoderm is the germ layer that gives rise to a variety of organs in the body, which includes bones and muscle, means that neurocutaneous syndromes can present themselves in a variety of organ systems, making them incredibly diverse. However, something they all have in common is that they are typically inherited congenitally, and so they present themselves in patients while they are young. They are also mostly characterized by the appearance of cutaneous stigmata or visible skin deformities, along with a variety of neurological symptoms, which usually include seizures and developmental disorders as a result of tumor formation. Treatments, unfortunately, this means tend to be palliative instead of curative, given the nature of these diseases. And today we will be focusing on tuberous sclerosis and Sturge-Weber syndrome as two examples of neurocutaneous syndromes with a special focus on tuberous sclerosis. So, tuberous sclerosis is a hereditary neurocutaneous syndrome that involves a variety of organ systems, including the brain, kidney, skin, retina, lung, liver, and bone. The incidence occurs in children between 1 in 12,000 and 1 in 14,000 births, and familial inheritance is autosomal dominant. Around 85% of the time, TSC results from mutations in two genes and the proteins they encode. These two genes are TSC1, which encodes hamartin, which we see here, and TSC2, which encodes tuberin, which we see here. These genes are transmitted on the long arms of chromosome 19 and 16, respectively. Given these two genes are present in all normal tissues, mutations can impact a variety of organ systems. Hamartin and tuberin form a complex that regulates a kinase called mTOR, which in turn regulates cell growth and proliferation, as we can see here, leading to abnormalities that can result in malformed or overgrowing tissue across multiple organ systems. However, the natural oncogenic effect of this kind of mutation can be blocked by administration of rapamycin. Moving on to diagnostic criteria, TSC, or tuberous sclerosis, is determined by either the presence of two major features or the presence of a major feature plus a minor feature. And here we can see several major features. Of special note, first of all, are cortical tubers right here, which present in 80 to 95% of cases and are strongly correlated with the development of epilepsy, making neuroimaging an incredibly important part of clinical diagnosis of TSC. Next, subepidermal giant cell astrocytomas are another key feature of TSC and are slow-growing benign brain tumors that develop in the ventricles of the brain. However, we also see facial angiofibromas and shagreen patches as important major signs. Here we can see two minor signs, and of special first, confetti skin lesions and retinal achromatic patches. And of special note, these are present in up to 87% of TSC patients. Moving on to management strategies, we see, first of all, like we mentioned before, rapamycin to control the oncogenic effects. And given that 96% of patients have dermatologic conditions, we will also be seeking treatments that basically on a case-by-case basis for these patients. Given that seizures are present in 80 to 90% of cases, vigabatrin is important for controlling infantile spasms, and everolimus is important for treatment of some brain and kidney tumors. But overall, these neurological manifestations, which include epilepsy, neurocognitive dysfunction, and behavioral problems, are the most common targets for patients with TSC. Moving on to Sturge-Weber syndrome, very different, right? It is caused by a mosaic somatic mutation in GNAQ, which we can see right here. And a mosaic somatic mutation is a DNA mutation that occurs post-fertilization, meaning there is a mix of cells that can have or not have the mutation present. It mainly affects the skin and CNS and is caused mostly by dysplastic vascular malformation in eyes, brain, and the face. And the affected vessels express more endothelin-1, which is a vasoconstrictive peptide, which can lead to chronic ischemia, which exacerbates seizure development and other neurological syndromes present in this disorder. Here we see a couple of diagnostic criteria, which include the typical congenital port wine stain, the typical oscular vascular malformations, and we can even see some of the port wine stain here as well, and the typical calcification of certain areas of the brain, which leads to a variety of neurodevelopmental disorders. And then finally, management strategies for Sturge-Weber syndrome include laser treatments for the birthmark, timolol and lantopraz for glaucoma treatment, given that glaucoma is present in the majority of cases thanks to those vascular deformities, and finally, anticonvulsants for seizures, which include these two right here. In summary, these are varied sort of diseases that affect multiple organ systems. The treatment is incredibly difficult, so it is mostly palliative. And finally, congenital inheritance means that early treatment works best since they are present in children. Thank you so much.